Good afternoon, everyone, or rather, should I say, good evening? Yeah. So my name is Dr. Mvundura. I'll be presenting a case of fetal arrhythmia. So I'm presenting a case of Mrs. L.R., 21-year-old housewife from Glenview, who was para 2 gravida 3 and EGA 29+1/40 at the time of presentation. So she came in as a referral from Glenview Polyclinic with an ultrasound scan obstetrics showing a fetal tachycardia of 224 beats per minute and amniotic fluid index of 45 centimeters, which has a polyhydramnios, fetal scalp edema, and a pleural effusion of 19 millimeters. The pregnancy was unplanned. It was due to failed contraception. She was on COCs, but she was not taking them regularly. And she did a urine pregnancy test after 3 months of amenorrhea. However, prior to doing the pregnancy test, she had developed nausea and vomiting, and she was treated as gastroesophageal reflux. So she was put on paracetamol and other drugs she couldn't recall. She booked late. At 27+5 weeks, they did an HIV test and syphilis test, which were both negative. So the patient had the past obstetric history of eclampsia in her second pregnancy, which was diagnosed postpartum. She had 2 children, 2 girls, both delivered by NVD term. They were alive and well. She has a positive family history of hypertension, no family history of cardiac disease or sudden death. She was not on any chronic medication, iron supplements. She was not put on low dose aspirin or calcium because of the late booking. The patient is in her second marriage, and she lives with her husband and 2 children. Her firstborn, who is now 5, was from her first marriage, and the second-born is the first child with her current husband. She does not smoke, take alcohol, or do any use any recreational drugs. So on examination, the temperature was 36.5 with a blood pressure of 104/65. A general examination was normal. And on the obstetric examination, the height of fundus was 31 centimeters, in keeping with the gestational age. Presentation was cephalic. Fetal heart rate was 220 beats per minute. So these were the ultrasound scan findings when she was scanned at the specialist clinic. Presentation was cephalic, tachycardia of 244 beats per minute. Left-sided pleural effusion was also noted. Skinny edema, polyhydramnios with the deepest pool of 11.9 centimeters. Of note, the ductus venosus A wave was absent, and it had high PI, but the rest of the Dopplers were normal. There were no obvious structural defects or markers of chromosomal abnormalities. The heart structure appeared essentially normal. So a diagnosis of supraventricular tachycardia was made. So here is the scan showing a fetal heart rate of 243 beats per minute. And on this scan, we can see that it was the atrioventricular ratio was 1:1. We are having an atrial contraction, which is followed up by a ventricular contraction. On this picture here, we see the pleural effusion. And on the following picture, that's the polyhydramnios. Here is the deepest pool of 11.94 centimeters. This is just the same picture. So as for the management, the patient was then put on flecainide, 100 milligrams POTDS, and the plan was to review 5 days for fetal heart rate monitoring. And a recommended delivery plan was by cesarean section. On the review scan, 5 days later, the fetal heart rate had improved. From 244, it had improved to 132 beats per minute to 137 beats per minute. The left pleural effusion, skin edema, polyhydramnios persisted. However, The ductus venosus A wave was now present, but it was reduced. The PI remained elevated, and the rest of the Dopplers were normal. So this is the fetal heart rate on the review scan, showing 137, a rate of 137 beats per minute. She was scheduled for review the following week. However, she went into preterm labor, which she described as which started as a rupture of membranes, which was followed up by uterine contractions an hour later, and she rushed to the hospital. About an hour after arriving at the hospital, she delivered, and that was described as precipitate labor. The birth weight was 1,755. ABGA score was 2 on 10 to 2 on 10. And unfortunately, the baby demised within hours. I'm now going to my discussion. Abnormalities in fetal heart rate and rhythm occur in about 1% of pregnancies. 10% of the arrhythmias are associated with potential morbidity and mortality, while the rest are benign. Estimated prevalence of fetal tachycardia is 1 in 100 to 200 pregnancies. However, locally, in a cohort of 2,700 scanned pregnant women, only 0.1% had arrhythmias. So this may point to us underdiagnosing fetal heart rate, fetal arrhythmias. So just go through classification of fetal arrhythmias. We can have bradyarrhythmias. The previous speaker presented on a case of bradyarrhythmia, which can be classified into sinus bradycardia, a blocked atrial bigeminy, atrioventricular block, and then the fetal tachycardias. We have sinus tachycardia. These ones are the ones that we usually diagnose, where we have maternal and fetal causes, with the maternal causes being maternal fever, endocrine disorders like hypothyroidism, maternal hypotension, and also fetal causes like fetal distress, severe prematurity, and also fetal activity. We also have supraventricular tachycardias. These originate in the atria, and these can be classified into short VA supraventricular tachycardias and long ventricular atrial interval supraventricular tachycardias and atrial flutter. We also have ventricular tachycardias, but these ones, they are very rare in fetuses. So I'll zoom in on short VA supraventricular tachycardias. This is the most common type, constituting 60% of all cases of supraventricular tachycardias. It typically starts with a premature atrial contraction that conducts through an AV node with a retrograde conduction through an accessory electrical connection, initiating a re-entry circuit. So in a normal heart, we have the cardiac, the heart skeleton, the fibrous skeleton acting as an insulation to prevent a re-entry of electrical activity back to the atria. But in this case, we have an accessory conduction pathway. The heart rates usually range from 180 to 300 beats per minute, and AV conduction is 1:1 with a short AV interval. They can be intermittent or sustained. If they are sustained, that is, they are present in over 50% of the time. So here's just a picture showing the accessory pathways. We can have an orthodromic, where the anterograde conduction is through the AV node, or antidromic, where the retrograde conduction is through the AV node. So here's an algorithm showing management of supraventricular tachycardias and atrial flutter. So in cases with no eye drops, flecainide is the first line treatment option. Then for those with eye drops, flecainide plus digoxin can be used. And if there's no response, we can always add another drug. Then for eye drops, digoxin has got a poor placental transfer, so usually it is combined with another drug. So in general, management of patients with fetal tachycardia, we do fetal heart rate monitoring. If the fetal tachycardia is intermittent, that is present in less than 50% of the time, or if the fetal heart rate is less than 200. And then principles of pharmacological treatment include normalization of fetal heart rate, prevention of heart failure, and increasing duration of gestation to term wherever possible, with the aiming to deliver the babies at 38 weeks of gestation. So just like what the previous speaker was referring to, we also have to screen these patients of the Torches infections, because cytomegalovirus, parvovirus can cause myocarditis, which can then trigger these arrhythmias. We also have to screen them for anti-Ro and anti-La antibodies. So as for the prognosis, hydrops fetalis occurs in half of all fetuses with tachyarrhythmias. Overall rate of fetal demise is 9% in untreated cases. If treated by transplacental drug therapy, rate of rhythm control is achieved in 80 to 90%. And 50% of fetuses with supraventricular tachycardia will develop postnatal SVT. So we have to do a multidisciplinary approach, and so that the pediatricians will take over the management of these fetuses post-delivery. Factors associated with the increased incidence of postnatal SVT include ventricular dysfunction, earlier EGA at delivery, and lack of conversion to sinus rhythm during fetal life. Atrial flutter is associated with good outcomes. It almost never once the infant undergo electrical cardioversion. So I'll end my presentation by these key takeaways. Fetal arrhythmias are being underdiagnosed, and when we do our fetal heart rate measurement, we should do it in the 4-chamber view using a 2mm sampling gate, and applying the gate below the AV valves and close to the interventricular septum, so that we get a good wave that we can analyze. And also when we look at the fetal heart, even either to obstetricians or the person who is managing the patient, we should not only look at the rate, but we should also look at the rhythm and the wave pattern. We can get more information from that. Then we need to refer these patients for fetal echo to fetal medicine, and these fetuses, they do benefit from intervention. That is, we can plan optimum delivery time, or else we can institute in utero treatment. Thank you very much.